Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, Anita Finley.
All right, well, now we're back with, I always call him the genius of the hips and knees. That's Dr. William Leone. So good morning.
Good morning. Thank you. Wow, what an introduction.
Yeah, well, we all think that about you. You know, it's funny if you're in a room with people and everybody saying, oh, I have to have some new hips or new knees, who would you suggest? And it's like a chorus of Dr. Bill Leone. So you've done this a long time, even though you seem so young.
Well, thank you. You know, as I was reflecting what I thought we should talk about this morning driving over, I was reflecting on, gosh, I started out as a young guy, and you turn around and it's now 26 years later. And you know, what's changed in 26 years? How's the experience for me and the experience for my patients just so radically changed in a very positive way? And
that's a great topic for our show this morning.
And then the question is, you know, why did it change? You know, what have been the incremental changes that now, when I look back just 5 years ago and 10 years ago, and certainly we were doing state-of-the-art in August of '89 when I started this practice, you know, how has it changed? And it was state-of-the-art back then. It's just that much better now.
We're going to let you move right on with this. This is a great topic. There's so many things I want to ask you, but I think that a lot of people who have had very good experiences would probably like to know why those experiences were so good, and are they going to even get better in the future?
Yeah, I think they are. I think what the audience doesn't know is when I first walked in, you asked me why your husband's knees, which were done near 25 years ago, are still really doing well. I mean, he said, you know, why aren't I having problems? And he happened to be reconstructed by an excellent knee surgeon who got it right. He used a prosthetic from that era that our history has told us was a good one. It wasn't an outlier, because there were some clear outliers. Some didn't do well. He got it aligned, meaning the mechanical axis was on. He got the soft tissues balanced. That was a lot harder to do then than it is now, because we have so many better technologies and we have better prosthetics. And he's not overweight and he didn't abuse it. Although I was also mentioning, I've seen a lot of people now who will come back after 20 or 25 years, hip or knee, who really are overweight, or they were super, super, super active with sports. And they've done well too. So a lot of it is just getting it right and having a prosthetic which didn't have flaws that we've learned now to avoid with a lot of them.
You know, I still see people, and this has come up, and I think it was important to share this with you. I know of someone who is very successful, very smart, and he's limping around, and he really does need new knees, and I've definitely told him to go see you. But he's afraid to do it because he keeps telling me about all the people who he knows who've now had blood clots or other kinds of problems. And I don't know what to say about that, but I know that you certainly will.
So again, when I think about what's so wonderfully and radically changed in my 26-year experience, has been more than a perception, this reality of how much quicker people get well, how much faster they get well, and how much quicker they get back to their normal lives. And it really began, it's so multifaceted. You can't put one finger on one thing and say that's it. It's because we're doing a lot of things better, and a lot of things is because we've learned, because it didn't work the other way or patients have taught us. But, you know, there's a lot more attention to pre-education, recognizing that if someone goes into the experience and their family goes into the experience, so the whole family, not just the patient, has a better experience and they have knowledge going into it, they have a lot less anxiety and they're going to get well quicker. And so there's a lot more emphasis, especially on the part of my office, helping them through this very convoluted process with a complicated medical system. So it's not, you don't come out of the system at the end feeling like it's post-traumatic. Nobody says it's a good experience, but it needs to be absolutely as good an experience as it can be. It's recognizing what ruins an experience. Well, not just all the the anxiety of getting cleared and getting to surgery and making it there on time, but nothing makes it worse than developing nausea or not being able to urinate after surgery or developing all these medical complications. And once again, our technologies are better. The anesthetic techniques are much better. The drugs they use are much more precise and shorter acting. The vast majority of my patients will choose to have their surgery with a very simple spinal.
I want to talk about that. We've never really done that. Tell me what the difference really is.
Well, one way or the other, you need to go to sleep. One way or the other, there needs to be absolutely no pain. But with a general, you're typically intubated, meaning someone has to put a tube down your throat, and then they have to give you drugs that, in essence, you're for a while paralyzed, and somebody breathes for you. And while the drugs are much better than they used to be, I think there tends to be more drugs that are given, and there tends to be more complications than if someone doesn't have to have that. They can just have their lower legs go to sleep for a couple of hours with a single injection placed into the spine below the spinal cord, called a spinal. Now, people said, oh, my goodness, that must hurt. The reality is it's a non-event. But then people will ask me, well, I don't want to be awake. Well, goodness, I wouldn't want to be awake either. And many of my patients, including myself, have had a colonoscopy or some procedure where the doctor does their thing, and certainly you wake up at the end, they have given you an IV, and you say, ooh, what a nice sleep, show me what you did. So it's the same thing. Once the spinal is in, then the doctor typically gives you some sort of anesthetic, typically propofol, and then you wake up at the end. So it's much smoother, unlike a light switch where it's on or off, and suddenly you awake after the general anesthesia. This is much smoother. One of the other things that we're doing almost routinely now is injecting the tissues around the hip or the knee with a, quote, local cocktail. It's some local anesthetic, it's some morphine, there's possibly some Toradol, which is a non-steroidal. Some people add a steroid. I think one of the biggest changes that I've seen in the last couple of years in my practice, it's made a wonderful difference, particularly for my knee patients, has been technology now that has allowed some pharmaceutical companies to lysomalize, if you will, a local anesthetic called ropivacaine, and so therefore this Exparel, this local anesthetic, will now come out of this surrounded molecule of fat much, much slower. So it means for the first, 30, 48 hours, there's almost no pain. So, imagine now waking up after surgery very slowly, and after a knee, which tends to hurt way more than a hip or a partial knee, and you're not hurting. You're good. And
I just want to interrupt you because I remember when Bill had both knees done at one time, and he was in recovery, and the nurse in recovery said, make sure at 11 o'clock that he gets more medication because he's going to be in pain. And yes, and I was there to make sure that happened because he did start. And then the next day, he was in pain, and they started to give him morphine, and he became allergic to it, and they wanted to give him something else. So what you're telling me now is fantastic.
If we can just get rid of all that trauma after surgery, and we've and so there's a huge emphasis, particularly in my practice, on people getting out of bed and starting to walk, not the next day, but the day of surgery. I mean, so even if surgeries, you get up to the floor at 2 o'clock, why not by 5 o'clock be at least standing and walking to the door or walking to the bathroom, whether it's a hip or a knee or a revision or, the partials are going home the same day, not because they need to, because they want to. Everyone would rather wake up in their own bed and go to their own kitchen and go to their own bathroom the next day. So the whole thing in a very positive way has changed. It's recognizing that I've eliminated almost completely eliminated the parenteral narcotics. When you give people narcotics intravenously, the buttons that people push that suddenly gives them a bolus of a local anesthetic or of a narcotic just make people feel sick. And it can create a lot of other problems, urinary retention, ileuses, and you don't feel good. It's up and down. So if you can know that the X pills are going to start wearing off, let's preempt pain. And I tell patients, you're going to take your pain pill, kind of like someone might take a blood pressure pill, not when you need it, but on a schedule for the first couple of days, and then you'll wean down. So we're preempting. So it changes the whole experience. No one wants to be exposed to a noxious stimulus. But if it's not, you're going to get well much faster. And then patients have taught us what they can do.
And Dr. Leone, I just want everyone to know who you are, because I'm sure people are listening and they're saying, okay, I want to call. Who is this? Dr. William Leone. He's the founder of the Leone Center for Orthopedic Care at Holy Cross. And it's Dr. Leone. And I have to say that. I mean, I just have nothing but stars to talk about with Dr. Leone. And it's really true. So let me give you a phone number. Remember, this is Pencil Talk Radio. Get your phone, get your pencil out. It's 954-489-4575. 954-489-4575. You can also, if you want, you can go online to Holy Cross Leone, Leone, Center.com. And before Dr. Leone continues, and I love everything he says, he's just so smart, and he really does care. When you think about it, and people are in pain, and they've been putting this off, and maybe you are going to get a first opinion, a second opinion, a third opinion. Go do it, but then figure out what you want to do. And no matter what other people say, don't listen to the people around the condo. Listen to the doctor that you decide on. Make sure he has the compassion and the experience and the success that Dr. Leone has. And I can't be too strong about that, because there have been things, and you've been reading the newspapers, and things happen to people, whether it's orthopedic surgeons or plastic surgeons. If you go to someone who's really experienced and takes the precautions that Dr. Leone does, it will only be a positive outcome.
Thank you.
Yeah, well, I know that you care so much about what you do, and it's obvious that you've done this a long time. So let's just go over to people who are having hips and knees. That's an interesting thing. Sometimes they don't know what they should have done first. Should they have their hip done? They should have their knee done. How do you determine that?
Typically, you do the joints that's the most painful, that's going to give someone the biggest, quote, bang for the buck, for the energy they put in. But it's not quite that straight a line. Not at all infrequently. Commonly, people that are experiencing knee pain, it may be coming from a problem from within their knee, but many times it's referred from another source, particularly the hip. So the hip can refer pain to the knee. I can think of many, many, many people, almost routinely, that will come in, and they have no pain in their hip. They think they have a knee problem, and it's really all from hip pathology.
Really?
So if someone has severe arthritis of their hip or significant arthritis of their hip, and they've even got a more symptomatic arthritis of their knee, then again, that may be an exception where it's more appropriate, more optimal for the patient to first have their hip replaced, because it tends to be an easier, more straightforward, quicker recovery. They have that under their belt. They have that confidence. They're not so scared of the system now. Because when you reconstruct a knee, you're trying to reconstruct not only an alignment, but a balance. You're not only trying to take a knee which may have some sort of an angular deformity, like a bow leg or a knock knee, and make it straight. You need to, not just because it looks better, because if you don't recreate, if you will, that neutral mechanical axis, i.e. if you were to drop a weighted line, a carpenter's plumb line, and it were to drop right through the middle of the ball of the hip joint and right through the middle of the ankle joint in a well-balanced joint, in a well-balanced knee, it should go through the middle of the knee, such that when you're standing up, the equal forces medially and laterally. So if a joint like your husband Bill's is to last 20 and 30 years, it needs to be balanced. So if you're now going to reconstruct a knee to make it a balanced neutral mechanical axis knee, then it starts with the hip, and if the hip now has pathology, it may behoove you to first start with the hip and create that point.
When Bill had his knees done, and this was before you, so of course he would have gone to you now, but at the time it was someone that you knew very well, of course. It was in your group.
Dr. Ed Williams did a wonderful job, and a very kind man.
Yes, and what was great is that Bill actually was bow-legged, and after he had his knees done, he has the most beautiful straight knees, and I think he gained an inch. So, I mean, it is interesting what happened, but at that point, see, he's had knees, too. He's had he's had hips done, which you, of course, have done. And so he's had, he's had to make those kinds of decisions, or you've had to help him make them. But he does walk straight. I mean, he's got that same position. And so it takes someone like you to really organize and think through this. All right, what am I going to do? How's that going to be? And then the last one that you did for him was pretty miraculous because you had to really bring in a lot of bone. And that was something that, I think is important.
Reconstructing a joint, replacing a hip or knee or a partial knee for the first time certainly has its issues and its complexities and its nuances, and there's a level of difficulty. But when you need to go back into a joint, which has now failed for a variety of reasons. It got loose, it wore out, it's infected, it broke, the bone around it broke. And that's a different level of how do you now take it out and not destroy too much tissue? How do you now remove the tissue which has become diseased or a problem? And then how do you see what's left so that you can go back to your principles to rebuild something that allows someone to walk pain-free, to dance or play golf or just, take care of their family and not hurt. And that's and every time you go back in, obviously there's less to work with and it becomes more of a challenge. And that's really what I cut my teeth with. That's really been something that I've taken a tremendous amount of pride in developing those skills.
Were you ever a sculptor?
I was, absolutely.
Because I just think about what you were saying and what you do. So that's been it's all part of it, isn't it? You see this as a work of art.
Oh, you have to see it ahead of time. I think the one thing that I really do have that I don't think most people have is that ability to see three-dimensionally, that ability to kind of know what it needs to look like and then what I need to do to get there with it.
Yeah, and also I know that you have been doing this for a long time, and the one thing that was very exciting for us is you did, and you talked about it, was the support team that you have, because that's so hard for someone.
Well, in this world, it's kind of a schism because the system is forcing a lot of changes, and some of the changes are good and some of the changes aren't good, but the emphasis is clearly on doing it for cheaper and clearly on proving outcomes, which is good. But there's a huge human element to what I do that we can't negate. And you can't just relegate to someone else. So there's less doctors, there's more physician extenders, which in many instances is very good. And it's a change, and these are sea changes from where we were 5 years ago and 15 years ago and 20 years ago. But our system, I bought a new phone yesterday and I spent 5 hours setting it up, and I'm still this morning messing, putting in my new codes, and, and I'm okay with it. I'm thinking of my mother who's 81 doing it. It's not going to happen.
Yeah, life is complex.
So everyone is trying to stay in place, and everyone's trying to take care of their families, all the doctors and all their staff. And so, and that's not, and the system, of course, saying we can't afford this, but there's more people that need it. So my practice has taken a very different turn where, I've very deliberately and said this can't just be about volume. I've done this. I was the busiest hip surgeon in all of Florida, and that doesn't matter. It's not the number. It's
the quality.
It's absolutely the quality. And it's the relationships. As beat up as doctors get these days from the system and the anxieties and what. On the other hand, what profession do people constantly come in and say thank you and bring me candy or write letters. It's just, it's the part of it that makes you get up at 5 a.m. and say, what a cool job. Did I ever make the right decision?
Right, and to come on to Anita Finley show on Saturday.
We're friends. And I just think the world.
Well, it's great because I think people are always concerned. They never get to hear this much from an orthopedic surgeon. You're very busy, and it's great because that's what they want to hear. Just like the Pope yesterday.
Wow.
That's why they all came out for him. Whoever gets to see the Pope, and that was
what a very special special man.
Wasn't that fantastic?
Very,
we all.
Very,
I think
very,
we were
very
all
kind.
Yeah, we were. That's true. We all felt the light, and we were just Dr. Mencia and I were talking about land of dreams in the United States of America. He said some wonderful things, but just getting back to what's happened, there's a lot of fear in going into these operations.
Well, that's why I think one of the things that's changed clearly is not just how quickly people mobilize, which is in my practice now the day of surgery, and not how quickly they go home, which quite honestly is typically the next day. Now, there's other circumstances. Maybe someone doesn't want to go home because it's an abuse. Once they're home, they have 3 kids, or
they have stairs,
or they've got
a
parent they're taking care of, or they all by themselves. No, there are instances where rehab is appropriate, but it is absolutely the exception now. Where in the days of yore, it was absolutely the rule. You're going home in 3 days? Goodness. No, people want to now. And it's because they go into with so much more organization. They know their plan before they start. And then my team, if you're going to really have a successful program like this, I have a team now. I people are called. And no, you don't like that? Come to the office. No, that someone didn't show up? We make a phone call. So it can't just be a one-sided deal here. It takes, all these little steps so that at the end, people really feel like they had a good experience. Because if you can go home, everyone's happier.
I remember when, and I just have to keep relaying what happened with Bill. We lived in a 2-story home at the time, and Dr. Leone had to do some major reconstruction on Bill's hip. And so he said to Bill, listen, if you want this to work and you want to go home, you have to promise me you're not going to put any weight on your hip for 30 days. It was 30 days. And so we had to have someone take Bill from an ambulance, a non-medical ambulance, picked him up, took him to the 2nd floor, and there he stayed until he had to go down and see you. Then we had to call them. But he's a very good patient. He's very disciplined. He did not put any weight on his leg, on his hip. And at the end of 30 days, Bill's hip, as Dr. Leone said, is perfect. He said, you're good. You're good to go. And he has had no problem. And you did some real major surgery. He would have been a cripple had you not dealt with this.
Again, one of the things that have changed in a very wonderful way is my ability now to do these way out there failed joints with better tools and with better prosthetics. And what allowed me to begin to do these 25, 26 years ago with these huge bone defects was using bone from someone else who had died, called an allograft bone. And our use of there's still a place for the use of the allograft bone, but in Bill's case, we used structural pieces of bone that had to make up for pieces that were missing. That's very seldom done now. And it's because we now have prosthetics and different metals and fibrometals that have 3-dimensional structures and different shape prostheses that allow me to do it and not risk the chance of a disease, allow me to customize it, and they don't stand the chance of collapsing later as blood vessels grow in, even though that would have grown bone. So again, we fortunately, keep pushing the ball forward. Sometimes we don't push it forward. We think we are. The world is, of course, living with this debacle now of putting in all these metal articulations that we had the thought, when they were going in that, well, maybe they're going to let young people have a joint that lasts longer. Well, that turned out to just be terrible. But, on the whole, we keep the not the whole profession, the whole art of it keeps going forward. It's our techniques are so much more refined. We have much better tools to put them in now, so there's less blood loss. It's all about being super gentle with tissues and being very, very precise. There's much more insight in terms of really correcting the biomechanics that led to the problem, and those then, like Bill, are the best results.
Well, I just can't thank Dr. Leone enough for coming here and doing this. Let me give you a phone number. Please write this down. It's very important. If it's not for you, it's for a friend, a family member. It's rare to find someone like Dr. Leone, especially to have him here in Fort Lauderdale. The phone number is 954-489-4575. 954-489-4575. And the website is holycrossleonecenter.com. And Dr. Leone will be presenting at the Cure Symposium. And he's a charming and very attractive man. You will enjoy it. He's going to bring some of the little apparatus that he uses. And please be sure to come. That's Saturday, October the 24th over at Palm Beach State College. And thank you, Dr. Leone.
It's such my privilege. Thank you.